Bismillahirrahmanirrahim. Today we will have a lecture titled Gout, the commonly wrong diagnosis. Gout, the commonly wrong diagnosis. Why I selected this strange title? Because we have already done uh, a research in our locality in Upper Egypt, and we found actually that gout may be wrongly diagnosed, or other cases, in fact, may be diagnosed wrongly as gout. So gout, false positive diagnosis of gout is very common in our locality. Introduction. Gout, as we all know, is a clinical disease associated with hyperuricemia and caused by the deposition of monosodium urate crystals in and around the tissues of the joints. Acute gout is one of the most painful conditions affecting mankind. Symptomatic crystal deposition includes attacks of acute inflammatory arthritis, chronic destructive arthropathy, and soft tissue deposition of monosodium urate crystals. The non-articular or soft tissue manifestations include tophi and precipitation of monosodium urate in renal collecting ducts, causing urolithiasis. The extent of the problem. The prevalence of hyperuricemia in adults is about 2.7%, and we insist that this is the presence of or the prevalence of hyperuricemia, not gout. The prevalence of hyperuricemia is 2.7%, and this is the hyperuricemia, not gout, and we will see later the difference between the two conditions. The prevalence increases, as we know, with advancing age. So in people over 80 years, the prevalence reaches 9% in males and 6% in females. More than 90% of cases are males, actually 95%. Six differences may be because estrogen facilitates tubular excretion of uric acid. This is some theories of why gout is more common in males. Also, the prevalence is more common in African Americans than Caucasian Americans, probably because of the higher prevalence of hypertension in Africans. The incidence of primary gout has doubled in the last 40 years, I mean from the 1980s until now. This may be because of change in dietary habits with increased Western diet habits, as we know, the fast foods, وجبات سريعة, and so on. Higher incidence of hypertension, obesity, what we know as the metabolic syndrome, increased number of transplantation recipients, and use of some drugs such as low-dose aspirin or diuretics, especially thiazide diuretics. Now, the title of our lecture, Gout, the commonly wrong diagnosis. Why? We have a dilemma in the gout diagnosis. This dilemma includes 7 points. Number 1, not all hyperuricemia are gout. Number 2, not all foot and ankle pain are gout. Number 3, not all big toe pain are gout. Number 4, gout is nearly exclusively a male disease, which is very, very rare in females. Number 5, gout is very, very rare in pediatric cases unless hereditary syndromes. Number 6, the old triad is totally non-specific. And number 7, the differential diagnoses are usually underestimated. Now we will take these one by one. Number 1, not all hyperuricemia are gout. The vast majority of hyperuricemic people will not develop symptomatic gout. In general, only 1 out of 30 subjects, around 3% only, 1 out of each 30 subjects with hyperuricemia will develop clinical gout. The development of symptomatic gout is related to both the severity of hyperuricemia and its duration. It was found that the risk of developing gout at uric acid level from 7 to 8 mg per deciliter, which is known as low hyperuricemia, the risk for developing gout is only 3%, and this increased to 22% in cases where the uric acid level exceeds 9 mg per deciliter, which is known as high hyperuricemia. And there is a very great debate of whether to treat or not to treat hyperuricemia if asymptomatic. But the general agreement is not to treat hyperuricemia unless symptomatic or unless there is a higher risk for this patient to develop, for example, urolithiasis. The second dilemma is not all foot and ankle pain cases are gout. This is the foot. As we see from this picture, every part of the foot has a very wide differential diagnosis, and pain in foot and ankle and toes may be due to very wide differential diagnosis. For example, medial malleolus fracture, posterior tibial tendinopathy, tendinitis, tarsal tunnel syndrome, subtotal arthritis, Baxter nerve entrapment, plantar fasciitis, which is very common, especially in our locality, calcaneus stress fracture, heel foot bad arthropathy, deltoid ligament sprain, midfoot arthritis, which is also common, tennis 2 and skier 2, bunion pain, turf 2, gout, hallux rigidus in the big 2, and we will see this in the next dilemma. Accessory navicular fracture, cochlear disease, molar Weiss syndrome, and mid-portion plantar fasciitis. All of these and others are the differential diagnosis of pain in the foot and ankle. This is, for example, the differential diagnosis of heel pain, just heel. It may be arthritic, gout, rheumatoid, seronegative. It may be infectious, diabetic, osteomyelitis, plantar warts, maybe mechanical due to trauma, for example, or mechanical minor trauma, neuropathic lumbar radiculopathy, nerve entrapment, neuroma, or tarsal tunnel syndrome, maybe due to major trauma or tumors such as Ewing sarcoma and neuroma, and finally for vascular causes. The third dilemma is not all big 2 pain are gout. Not all big 2 pain are gout. Causes of pain in the big 2 may be bunion, arthritis, gout, sesamoiditis, or turf 2. Here the most common differential diagnosis of pain in the big 2. Pain in the big 2 may be gout. Gout is caused by the build-up of uric acid crystals that look like needles, such as this. This is the picture under the microscope. Hallux valgus or bunion deformity. It may be due to, for example, rheumatoid arthritis or trauma or other causes. Deformity is characterized by lateral deviation of the big 2 with enlargement of the tissues around the metatarsopharyngeal joints. This may be traumatic or after a long period of, for example, rheumatoid arthritis or other inflammatory condition. TERF2 is the common term used to describe an injury to the plantar plate and sesamoid complex of the MTB of the big 2, metatarsopharyngeal joint of the big 2. And sesamoiditis, from its name, it is inflammation around the sesamoid bones. There are 2 sesamoid bones, one tubular and one fibular, under the big 2. The sesamoid bone acts like pulleys for the flexor tendon and are embedded into the tendons of the flexor hallucis brevis muscle. Sesamoiditis is generalized big toe pain at the bottom of the big toe. You should differentiate all of these conditions from gout. Number 4. Gout is exclusively a male disease. So, can we see gout in females? Gout is very uncommon in female before menopause. Only less than 5% of gout cases are females, and out of these, 90% occur after menopause. Postmenopausal gout is similar to usual male gout in all aspects except that the age of onset is later. Postmenopausal gout is associated more than male gout with diuretics, especially thiazide diuretics, in over 95%, hypertension 73%, renal insufficiency 50%, and pre-existing joint disease such as rheumatoid, for example, or osteoarthritis. Moreover, premenopausal gout mostly occur in females with hypertension and renal insufficiency, and premenopausal women with gout and normal renal function should be evaluated for hereditary causes such as the autosomal familial juvenile hyperuricemic nephropathy and rare non-X-linked inborn errors of purine metabolism. So, premenopausal female gout, search for the hereditary causes. Why gout is more common in males? This is because of the normal physiology of urate metabolism. In children, the level of serum uric acid is relatively low, 2 to 2.5 milligram per deciliter. This is the case in both sex, male and female, before puberty. This level rises rapidly in male around the age of puberty till the maximum level, which will thus persist for life. Every person has his maximum level. So if my level is 6, this is maximum level of me. So my uric acid will increase rapidly from 2 or 2.5 to 6 within few years after puberty. This is in male. But in females, the level of uric acid rises gradually after puberty till it reaches its maximum only after menopause. So, if you can draw, the level of uric acid in male is low before puberty and increase rapidly at puberty and then continue it as maximum. So, at this level, it may increase to hyperuricemia and then gout. But in female, it is low. After puberty, it increases only gradually until reach this maximum at menopause or after menopause. Number 5. Gout is exclusively an adult disease. We have here two conditions. There is early onset gout, which mean gout before the age of 25, not 16, not pediatric. It is early onset adult gout. Only around 3 to 6% of gout may occur before the age of 25. So only less than 6% of gout will occur before the age of 25 in males. Early onset gout is usually associated with genetic problem. The family history of gout is positive in 25% of cases in usual gout, but this ratio increased to over 80% in the early onset gout. These cases show more accelerated course and need more aggressive treatment regimens. However, juvenile or pediatric gout, which is before the age of 16, is rather more rare compared to the early onset gout, which affect people from 16 to 25 years old. Number 6. The old triad is totally non-specific. The old triad of acute monoarthritis, high serum uric acid, and rapid response to treatment used in the past to diagnose gout should be taken cautiously because response to treatment may occur in other arthritis such as other crystal-induced arthritis or even other types of arthritis, because actually we treat the acute gout with non-steroidal colchicine and steroid, all of which are anti-inflammatory in fact, and may treat any type of arthritis we can see. So the response to treatment is not a sign for success of diagnosis. Number 7 and last dilemma. The differential diagnosis of gout is usually underestimated. As we see in 2 and 3, not all big toe and foot and ankle pain are gout, but this differential diagnosis is usually underestimated, especially in the non-rheumatology specialists. So, there are challenges affecting proper diagnosis. The number one is specialty. As we will see later, the specialty is very important for correct diagnosis for gout. In non-specialized doctors or physicians, there may be a problem in the update knowledge around gout. Many of the non-rheumatology physicians have already data or knowledge around gout from 20 or 30 years ago when they are or when they were a student for undergraduate medicine. This will lead to overdiagnosis in less in most of the cases in non-rheumatology, for example, and less commonly underdiagnosis trend of some physicians. So the majority of physicians will have overdiagnosis for gout, and less commonly some may have underdiagnosis trends for some physicians. This is maybe due to lack of specific tests. There is no specific test unless polarizing microscope, which is not available everywhere, and also it is not sensitive. It is specific but not sensitive. And finally, the challenge is the self-limited nature of acute attack, which will apparently respond to nearly any treatment because it is already self-limited. If the patient didn't receive anything, he will cured or improve within few days and a maximum of 2 weeks. So the self-limited nature of the acute attack may have some challenge for correct diagnosis because some doctors may give the patient non-steroidal steroid and the patient improves, so this is gout. No, this is not gout. It is not the case in all cases. As we said before, the differential diagnosis of gout may include other crystal-induced arthropathy such as CBPD, the pseudo-gout, basic calcium, appetite, or liquid lipid. Other causes of acute monoarthritis such as infection, trauma, or sarcoidosis. And early cases of chronic polyarthritis such as rheumatoid arthritis may be presented with monoarthritis, and this is the differential diagnosis of monoarthritis and not of pain in the big toe, as we said before in number 2 and 3 of our dilemma and the diagnosis of gout. So, some may use classification criteria for the diagnosis of gout or classification of gout. In fact, we will return to the previous slide with the lack of update knowledge in non-specialized non-rheumatologist, because the gout had very huge number of classification criteria before the 2015 classification criteria of ACR and EULAR. We will rapidly jump for these criteria. Rome criteria 1963 with 4 criteria, and we need 2 or more of these criteria. I will not read these criteria because to save time, You can stop here and read as you want. This is followed by New York criteria in 1966, or also have 4 criteria, and we need 2 or more, or the presence of MSU crystal, monosodium crystal, in synovial fluid or tissues. The ACR, formerly known as ARA, American Rheumatology Association, the new name is ACR, American College of Rheumatology, classification criteria for 1977, which is called Wallace criteria. This is the full version with 12 criteria, and we need 6 or more criteria, or the presence of monosodium urate in joints or tophi. So the presence of monosodium urate crystal seen by the polarized microscope is sufficient criteria to diagnose gout. This is the only sure sign, but it is non-specific. This is the Survey criteria, or Survey version of the criteria of Wallace, with only 11 criteria, and we need 6 or more criteria to classify as gout. In 2007, the Mexico criteria included 8 criteria, and we need 4 or more, or the presence also of MSU crystals. In 2010, the Netherlands criteria was the first criteria to include points rather than counting of criteria. So male 6 take 2, previous patient reported arthritis take 2, and so on and so on. And presence of 2-5-13, and we need 8 points to diagnose as gout. Between 4 and 8 suggest need for synovial fluid analysis. Before less than 4 exclude gout, and more than 8 suggest gout. And as we see, 2-5 take the score of 13. So if we have 2-5, we will not continue with the criteria. We will diagnose as gout directly. Problems of all these criteria: the low sensitivity and specificity of these criteria. It is very major problem of all these criteria. Not internationally agreed except Wallace classification criteria. All items has the same weight except for Netherlands, as we said before, and not cover all the aspects of the disease. There is no mention for bursitis, for example. Finally, we have the new 2015 ACR EULAR classification criteria, ACR American College of Rheumatology, EULAR European League against Rheumatism criteria. This criteria have one entry criterion, which is the presence of one episode, at least one episode of swelling, pain, or tenderness in a peripheral joint or bursa. If we have no entry criteria, we will not continue, we will exclude gout. If we have the entry criteria, we will jump to the sufficient criteria. If we see monosodium urate crystal in the symptomatic joint or bursa, we see the monosodium urate crystal by the polarized microscope, we will diagnose gout. So this is sufficient criteria. We will not continue, we will diagnose directly as gout. If we have entry and not have sufficient criteria, we will jump to the third step, which is the counting of scores. As we all know, these are the criteria for 2015 ACR criteria for classification of gout. You can stop here and read carefully as you want, because I will save time and not read it. So, finally, we did already a study in our locality in Sohag University, Upper Egypt, and we now expanding the study to include more than one university, more than one center in Egypt. We may include Upper and Lower Egypt at the same time. So it is just ongoing work, but the primitive result of this study includes the prevalence of wrong diagnosis of gout. In our pre-published study done in Department of Rheumatology, Sohag University, Upper Egypt, 147 cases previously diagnosed as gout, and already we were taking management of gout in the form of urate-lowering drugs such as allopurinol or febuxostate, colchicine, or both. So we included cases diagnosed already as gout and receiving already urate-lowering drugs plus minus colchicine. We found that the total number of the studied cases were, as we said, 147, but out of these, only 46 cases, such 31.3%, only of these cases fulfilled the 2015 ACR EULAR classification criteria as gout. The specialties of the following physicians and their accuracy in diagnosis are summarized in the following tables. We found that out of the 147 cases, only 27 cases, 18.4%, were followed by rheumatologist specialists, and all of these cases are correctly diagnosed except three cases. So the accuracy for diagnosis was 85.2%. This is accuracy according to the 2015 criteria, and we should know and be aware that this criteria is used only for research and classification and not for diagnosis. So individually it is not 100% accurate. We know this, and this may be the cause of the presence of 3 cases followed by rheumatologists diagnosed as gout but not fulfilling the criteria. We will jump to other specialties. Orthopedic surgery seen around 43.5% of these cases, 64 cases, and the accurate diagnosis or the correct diagnosis according to the 2015 criteria was only 21.9%. Internal medicine specialists followed 20 cases, 13.6%, and the accurate diagnosis was only in 20%. Neurology followed 7 cases, 4.8%, with accuracy of only 14.3%. Only 1 case fulfilled the criteria, and the other 6 didn't fulfill the criteria. Other specialties, including chest, oncology, dermatology, and so on, followed 12 cases with 16.7 accuracy for diagnosis. We will be surprised that physiotherapists, not physicians, not doctors, physiotherapists of the physiotherapy college, faculty of physiotherapy, not of medicine, physiotherapists followed 17 cases, and only 2 of these 17 were accurately diagnosed as gout, and around 90% were wrongly diagnosed as gout. The correct diagnosis of these cases in general include many other defective diagnoses. The most common of these was plantar fasciitis and monoarticular involvement of other causes such as pseudogout or rheumatoid and so on and so on. Some cases have trauma and diagnosed as gout and so on. So, take a home message. Gout is widely overdiagnosed in our locality, with the vast majority of cases diagnosed and treated as gout are actually having other problems or even just asymptomatic hyperuricemia. You should revise every case coming to you with previously diagnosed gout, especially if it was followed by non-rheumatology specialists. Remember that even established gout cases don't necessarily need urate lowering drugs, which means that gout is both overdiagnosed and overtreated. And thank you. So if this lecture was beneficial for you, you can subscribe in our channel Rheumatology Made Easy. We will record all of my lectures uh, later on in the near future, inshallah. And we are very happy if you are benefited from this lecture, and meet you in the near future with other subjects and topics. If you need special topics, just send to me in the just write in the comments in the comment of this video, and we will put these lectures or topics in the near plan for this channel. And thank you very much.